Hello dear friends, I know it's been a long time we didn't meet, but this was that at that time I had some obligations, some papers to finish, some lectures to give, but I promise you that this won't be repeated again, and we hope that we can finish the series of applied neuroanatomy as soon as possible. Today we are going to discuss the anatomy of a very important part. It is an extracranial part, but it's in our way in many of the approaches to the skull base. That's why we have to understand, and you have to have at least good knowledge of the structures in these regions, in the infratemporal fossa, Pterygopalatine fossa, and the parapharyngeal fossa, so that we can preserve the structure, the important structures in this region, in our way to the skull base. We start by the infratemporal fossa. It's a complex area, deep to the masseter muscle and zygomatic arch. If you feel the cheek, lateral, behind the orbit, you can find the zygomatic arch, and from below the zygomatic arch you find the masseter muscle, and it contains some of the muscles of mastication. You know that the muscles of mastication are 4. We have inside the infratemporal fossa 2 of them, the medial and lateral pterygoid muscles, and as you all know, the infratemporal fossa is closely related to the temporal fossa above and the pterygopalatine fossa medially. The importance of the infratemporal fossa actually is that it is a very important pathway for neurovascular structures from and to the cranial cavity and to the temporal fossa and pterygopalatine fossa. Also, the lateral pterygoid muscle divides the infratemporal space, infratemporal fossa, into 2 parts: superficial part containing the maxillary artery and a deep part containing the mandibular nerve. So most of the cases the maxillary artery is superficial to the lateral pterygoid, but sometimes, not usually, you can find it deep. But on the whole, the nerve is deep to the muscle and the maxillary artery is superficial. This is a view of the skull from below, showing you the confines of the infratemporal fossa. So as we said, it is deep. This is the zygomatic arch and the masseter and the mandible, and it is deep to this region is the infratemporal fossa, and it is bounded, it is in front of the temporomandibular joint, and the roof is the greater wing of the sphenoid containing the foramen ovale and foramen spinosum. Maybe at this side is clear, ovale and spinosum, and it is bounded medially by the pterygoid plate. You have here the medial pterygoid, lateral pterygoid plates, and it is anteriorly it is bounded by the maxilla, as you see. So zygomatic arch, masseter muscle, roof, ovale and spinosum, medially the pterygoid, and anteriorly the maxilla. The boundaries of the temporal fossa, as we said, laterally it is the condylar process and ramus of the mandible, which is the lateral is here, the mandible is here, so the ramus of the mandible is the lateral boundary of the infratemporal fossa, and the condylar process, this is condylar process is here, and medially, as we said, the lateral pterygoid plate containing the tensor palati, tensor tympani, and also the superior constrictor of the pharynx. So, of course, what is medial here is the pharynx. Here, what is medial here is the lateral pterygoid plate and the tensor palati, tensor tympani muscles. And anteriorly, as we said, it is the posterior border of the maxillary sinus, and posteriorly the carotid sheath, and the roof is the greater wing of the sphenoid containing foramen ovale and spinosum, and the floor is the medial pterygoid muscle. So the medial wall of the infratemporal fossa contains the lateral pterygoid muscle, but the floor contains the medial pterygoid muscle. We'll see it right now. So this is a view of the infratemporal fossa. This is the zygomatic arch, this is anterior, and we removed the lateral wall of the infratemporal fossa, which is the ramus of the mandible and the condyloid process, temporomandibular joint, forming the lateral boundary. So the lateral boundary again is the ramus of the mandible, which is cut, and of course the masseter muscle. The medial boundary, as we said, is the lateral pterygoid plate and the pharynx. This is lateral pterygoid plate and the pharynx. And also you can say that the medial wall also is the pterygoid muscle, the lateral pterygoid muscle. And the roof, of course, is the infratemporal surface of the sphenoid containing ovale and spinosum, and the posterior wall is the carotid sheath here with the tympanic plate and the styloid process. This is styloid process, tympanic plate in front, a bone in front of the external auditory canal, and as we said, the medial wall, the lateral pterygoid plate, and you know that the lateral pterygoid muscle, one of the heads arise from the lateral pterygoid plate. So again, it is a fossa deep to the ramus of the mandible and the masseter, forming the masseter and ramus of the mandible, forming the lateral boundary, and the medial boundary is formed of the lateral pterygoid plate, lateral pterygoid muscle and the pharynx, and anteriorly we have posterior surface of the maxilla, and posteriorly you have the carotid sheath and the tympanic plate, styloid process, and the roof we have the outer surface of the greater wing of the sphenoid, or the infratemporal surface of the sphenoid containing foramen ovale and spinosum. Contents of the infratemporal fossa, as we said, there are muscles, and the two muscles in the infratemporal fossa are the medial and lateral pterygoid muscles, which are two muscles of mastication. The other two, temporalis and masseter, are inserted around the infratemporal but not from the contents. And it contains a very important artery, which is the maxillary artery, which is the terminal branch of the external carotid artery together with the superficial temporal artery within the substance of the parotid, and of course the branches of the maxillary artery. And it contains a nerve, the mandibular nerve V3, which is the third division of the trigeminal, and the branches of V3 as you will see it, but it also contains the chorda tympani of the facial nerve and the otic ganglion. And the veins, of course, you have to know, or you all know the pterygoid venous plexus, which is connected with the cavernous sinus, and retromandibular vein. So contents, muscles, arteries, nerves, and veins. Muscles, medial lateral pterygoid, arteries, maxillary artery and its branches, nerves, mandibular nerve, chorda tympani, and the otic ganglion, not the sphenopalatine ganglion. Otic ganglion, parasympathetic for the parotid, receiving from the lesser superficial petrosal nerve and innervating the parotid gland, and the veins, as we said, pterygoid venous plexus, very important plexus, and the retromandibular veins. These are the contents. You should know what is written. You shouldn't go all through these details. As we said, what we said is more simple, but it all comes to the same end: muscles, nerves, arteries, and veins. The muscles of the infratemporal fossa, as we said, the two muscles are the medial and lateral pterygoid muscles, with the parts terminal ends of the temporalis and masseter, and each muscle of the pterygoid has two heads. The medial pterygoid has a superficial and a deep head, as we'll see, and the lateral pterygoid has superior and inferior head. Sometimes the medial pterygoid is called the inner pterygoid muscle, and the lateral pterygoid is called the outer pterygoid muscle, and the heads of the lateral pterygoid, we can call them upper and lower head, or superior and inferior head. And as we said before, the lateral pterygoid muscle forms a part of the medial wall of the infratemporal fossa, as it arises from the lateral surface of the lateral pterygoid plate, as we saw before, and the medial pterygoid muscle forms the floor of the infratemporal fossa. And as we said before, the lateral pterygoid divides infratemporal fossa into a superficial part containing the maxillary artery and a deep part containing the mandibular nerve in most of the cases. So here, this is the outer pterygoid or the lateral pterygoid muscle, and here is the medial pterygoid or the medial pterygoid muscle. And as we said, the lateral pterygoid is lateral to the medial pterygoid, and the lateral pterygoid muscle has got an upper head and a lower head, or a superior head and an inferior head, and the upper head arises from the sphenoid ruff, from the outer surface of the greater wing of the sphenoid, and the lower head arises from the lateral surface of the lateral pterygoid plate, and it is forming the medial wall of the infratemporal fossa. And the medial pterygoid has got a superficial head and a deep head. The superficial head, posterior surface of the maxilla, maxillary tuberosity, going to the angle of the mandible from below, and the deep head is coming from the deep surface of the lateral pterygoid plate. So the lateral pterygoid plate gives origin to the two pterygoid muscles. It gives origin, the lateral surface of the lateral pterygoid gives origin to the lower head of the lateral pterygoid muscle, and the inner surface of the lateral pterygoid plate gives origin to the deep head of the medial pterygoid muscle. So these are the two muscles. Again, this is the lateral or outer pterygoid, and this is the medial pterygoid. Lateral pterygoid inserted near the condyloid process, and here it is inserted at the junction of the body and the ramus of the mandible from inside. The second content after the muscle, as we said, the maxillary artery, and as we said before, it is one of the two terminal branches of the external carotid artery within the substance of the parotid. It rises posterior to the neck of the mandible in the substance of the parotid, and it divides into the superficial temporal and maxillary, the carotid, external carotid artery, and the maxillary artery, as we said, passes in the superficial compartment of the infratemporal fossa, superficial to the lateral pterygoid, but sometimes deep. And it is divided into three parts by the lateral pterygoid before reaching the muscle, lateral to the muscle, and beyond the lateral pterygoid, or 1, 2, and 3, first, second, third parts. And here is a view, external carotid artery behind the angle of the mandible, behind temporomandibular joint, dividing in the substance of the parotid into a superficial temporal and maxillary artery, passing in the infratemporal fossa with its branches. And again, this is to show you that the maxillary artery has got many branches inside the infratemporal fossa. And we talk about the branches. It's very easy to remember. You don't have to remember them by heart. It's very logic. When you see the logic, you can remember them very easily. The part before the lateral pterygoid muscle, the branches are Mayada. Mayada is the name of pretty girls in Egypt or in the Oriental region, and M goes for the middle meningeal artery, then the inferior alveolar artery, then the accessory meningeal artery, then the deep auricular and anterior tympanic. So middle meningeal, inferior alveolar, accessory meningeal, deep auricular, anterior tympanic. The second part, which is lateral to the lateral pterygoid muscle, gives muscular branches. So it gives the deep temporal arteries, which are important to the temporalis, which is of utmost importance. Please, when you remove or you dissect under the temporalis muscle, please don't injure the deep temporal arteries. Don't use diathermy, don't use bipolar to dissect the muscle. If you lose this, you get atrophy of the temporalis muscle. It's really disfiguring, disfiguring for the patient to have an atrophic temporalis muscle. So you have to keep it safe. So if you have this atrophy, you can ask some of the colleagues of dermatology to inject some fat in the temporal region, but better to keep the muscle with its blood supply. And of course, the three muscles are the pterygoid, medial, lateral, and masseter. So the part lateral to the lateral pterygoid, muscular branches, temporalis, pterygoids, median and lateral, and masseter. The part after the lateral pterygoid, beyond the lateral pterygoid, or the third part, branches with the nerves. So Mayada, muscular branches with the nerves, continues as the infraorbital artery, if you remember, in the infraorbital canal with the maxillary nerve, and the posterior superior alveolar artery. We'll see it now, don't panic. And the sphenopalatine artery, the very famous sphenopalatine artery, which are all, we all want to preserve when you do the nasoseptal flap, you remember, the Haddad flap, because it is giving this flap and you use it vascularized, and the greater and lesser palatine arteries, of course, the ascending pharyngeal artery of the external carotid, and the pterygoid artery, artery of pterygoid canal, or the Vidian artery. Let's see now. Imagine this is the lateral pterygoid muscle. What is before the lateral pterygoid muscle is Mayada, the middle meningeal artery, the inferior alveolar artery, the accessory meningeal artery, the deep auricular artery, and the anterior tympanic artery. The second part gives muscular branches, as we said, which are the branches to the lateral pterygoid, medial pterygoid, masseter, and temporalis. And the third part gives branches with the nerves. So the infraorbital artery is the continuation of the maxillary artery, infraorbital foramen with the maxillary nerve. And we are supplying from posterior and up. So it's called the posterior superior alveolar artery. And we have, of course, the famous sphenopalatine, then the greater and lesser palatine arteries, and the pharyngeal branch, and artery to the pterygoid canal, which is the Vidian artery. So again, for the third part, continuation infraorbital, as it gives the maxilla, the upper maxilla from posterior and upper, so it is posterior superior alveolar artery, the very famous sphenopalatine, greater lesser palatine, pharyngeal, and the Vidian artery or artery of the pterygoid canal. The second thing we are going to talk about, the third thing after the muscle and the artery, the mandibular nerve. It is the third branch of the trigeminal, V3, and it passes from the skull through the foramen ovale, then in the infratemporal fossa, deep to the lateral pterygoid muscle. If you remember, we said it before. And all know that the foramen ovale carries also the accessory meningeal artery, emissary vein, and the lesser superficial petrosal nerve. The greater superficial petrosal passes through the pterygoid canal, but the lesser passes in the foramen ovale with the mandibular nerve. And of course, it is the only mixed branch of the trigeminal containing motor and sensory branches, and the motor branches are supplying the four muscles of mastication: the mylohyoid, anterior belly of digastric, tensor palatine, tensor tympani, if you remember from the anatomy, and you will see it now. And the sensory branches are meningeal branch, the buccal nerve, auriculotemporal nerve, the lingual and inferior alveolar nerve. And we'll see their supply in the figure. So this is the view, infratemporal fossa, and this is the mandibular nerve in the infratemporal fossa. Has a main stem, has got an anterior division and a posterior division, and these are the divisions of the nerve. So trigeminal ganglion, foramen ovale, mixed nerve. The green is for the sensation and the red is for the motor, and it has a main trunk. The main trunk gives branches, muscular branches and sensory branch. What is the sensory branch? It is the meningeal branch supplying the dura of the middle fossa. The muscular branches are to the tensor tympani, tensor palatine, and the medial pterygoid muscle. So the medial pterygoid is supplied by a branch from the main stem. Then the mandibular nerve divides into an anterior division and a posterior division. The anterior division is mainly motor and it ends at the sensory branch. Posterior division is mainly sensory. So let's talk now the anterior division, mainly motor, giving the rest of the muscles of mastication but the medial pterygoid. So it gives the temporalis, the lateral pterygoid, and the masseter. Then it continues as a sensory nerve, which is the buccal nerve, supplying the skin of the anterior part of the cheek, supplying the buccal mucosa, and supplying part of the gums opposite second and third molar teeth. It's not important. It's just supplying the cheek and the skin of the cheek anteriorly and the buccal mucosa. The buccal nerve supplying the buccal mucosa. This is the anterior division. As we said, the posterior division is mainly sensory. So it's giving sensory branches. It is giving the auriculotemporal nerve. It's giving sensation to the parotid gland and to the temporomandibular joint. Also, it continues as the lingual nerve, which is a sensory nerve, sensation, general sensation, pain, temperature, and touch from the anterior 2/3 of the tongue. The facial, chorda tympani, taste from the anterior 2/3 of the tongue, special visceral sensation, but the lingual, general visceral sensation, pain, temperature, and touch from the anterior 2/3 of the tongue, and it contains a branch from the chorda tympani, as we'll see, supplying the parasympathetic to the sublingual and the submandibular gland, and relaying in the submandibular ganglion. So this is the anterior division or anterior part of the mandibular, posterior part and the posterior part of the mandibular. Also, it gives the inferior alveolar nerve, which is supplying the lower teeth, which is supplying the gums, which is supplying the skin over the lower part of the mandible, apart the angle of the mandible, which is supplied by C2. It is mainly sensory. Lingual nerve is a very important sensory nerve. Inferior alveolar is a very important sensory nerve, and it gives sensation, as we said, to the temporomandibular joint, parotid, and auriculotemporal nerve, sensation in front of the ear, and the external canal and the temporal region. And it contains a motor branch less important, which is the nerve to the mylohyoid muscle, passing in a groove in the medial wall of the mandible, if you remember, and through the mandibular foramen, supplying the anterior belly of digastric and the mylohyoid. So anterior belly of digastric supplied by V3, posterior belly of digastric by the fascia. And for further information, you can go back to the mandibular nerve. Here is to show you that this is the chorda tympani. It joins the lingual nerve and it passes and relays in the submandibular ganglion to supply parasympathetic supply to the submandibular sublingual salivary glands. It's not the lingual nerve, it is hanging in the lingual, but the lingual nerve has nothing to do with this gland. Only the sensory fibers are passing without any relay inside the submandibular ganglion. And as we said, the chorda tympani carries the parasympathetic, as we said, as well as sensation of taste from anterior 2/3 of the tongue. And it is reaching the tongue by joining the lingual nerve. Communication of the infratemporal fossa, very logic. Don't try to memorize just by heart like that. Of course, the infratemporal fossa is below the temporal fossa. So there is a gap deep to the zygomatic arch communicating with the temporal fossa from above. And the roof of the infratemporal fossa is the cranial cavity. So it is communicating with the cranial cavity through the foramen ovale and foramen spinosum and foramen lacerum, which is normally closed by cartilage. Remember, the artery carotid passes above the lacerum, it doesn't pass through the lacerum. There is a cartilage closing the lacerum. So this is the communication with the up and the temporal fossa superficial and up deep the cranial cavity. Anteriorly, it is communicating with the orbit through the inferior orbital fissure, which is formed by the greater ring of the sphenoid and the maxillary bone. If you remember this, inferior orbital fissure carrying veins, and medially the infratemporal fossa is communicating with the pterygopalatine fossa through the pterygomaxillary fissure, as you will see. So these are the four communications of the infratemporal fossa: above superficial with the temporal, above deep with the foramina, anteriorly inferior orbital fissure with the orbit, and deep or medially with the pterygopalatine fossa through the pterygomaxillary fissure. Now we'll talk about the pterygopalatine fossa. Pterygopalatine fossa is a cone-shaped depression, of course deep to the infratemporal fossa and posterior to the maxilla. So it is, from the name, it is between the pterygoid processes and between the palatine bone, and it is deep to the infratemporal fossa and posterior to the maxilla. And this space allows is a transitional space of several important structures through different foramina. The pterygopalatine fossa has access to many regions through different foramina, and the contents are mandibular nerve, the sphenopalatine ganglion, which is the parasympathetic ganglion, sometimes called the pterygopalatine ganglion, hanging in the mandibular nerve, not relaying inside the fibers, but actually it is a parasympathetic ganglion for the facial nerve supplying the lacrimal gland. So as we'll see, the greater superficial petrosal nerve, branch of the facial nerve, passes in the pterygoid canal and relay in the sphenopalatine ganglion, and the postganglionic fibers pass to supply the lacrimal gland. So if you injure the sphenopalatine ganglion, you get decreased lacrimation, not stopping of lacrimation, because we have the accessory lacrimal gland. This is from God's mercy that we have accessory lacrimal glands keeping your eye wet. And we have the descending palatine artery, as we'll see, and the Vidian nerve and artery, or the Pterygopalatine artery or pterygoid artery and nerve. So these are the contents: a nerve, a ganglion, and two arteries, descending palatine and Vidian. So let's see, where is the Pterygopalatine fossa? It is medial to the infratemporal fossa. It is between the pterygoid and the maxilla. It is communicating with the infratemporal fossa laterally through the pterygomaxillary fissure. It is inverted pyramid. It has a base here and a summit here. Pterygopalatine fossa, this figure to show you that the Pterygopalatine fossa communicates laterally with the infratemporal, as you know, to pterygomaxillary fissure, and communicates medially with the nasal cavity through the what we call the sphenopalatine foramen. So laterally you all see it communicating with the infratemporal. If you go medially, you will find the nasal cavity through what we call the sphenopalatine foramen between the sphenoid bone and the palatine bone. This is the sphenoid bone, here is the palatine bone, as you will see. And again, the pterygopalatine fossa communicating laterally through the pterygomaxillary fissure, communicating, having superiorly the greater wing of the sphenoid, having posteriorly the pterygoid process, having anteriorly posterior surface of the maxilla, having medially and inferiorly part of the palatine bone. So medially the perpendicular plate of the palatine bone, and the floor inferiorly the pyramidal process of the palatine bone. So again, anteriorly the maxilla, posteriorly the pterygoid plate, superiorly the greater wing of the sphenoid, medially the perpendicular plate of the palatine bone, and the floor the pyramidal process of the palatine bone. It looks like a pyramid. These are the boundaries of the pterygopalatine fossa. Here the mandibular nerve inside the pterygopalatine fossa, inverted pyramid, having the sphenopalatine ganglion or pterygopalatine ganglion, and as you see here, that the greater superficial petrosal nerve and passes in the sphenopalatine ganglion, relaying in it, supplying parasympathetic to the lacrimal gland, and also the lesser superficial petrosal nerve is passing but not relaying in this, because the lesser superficial petrosal of the glossopharyngeal relay in the otic ganglion, sway to the parotid gland. So here to show you that one of the contents of the pterygopalatine fossa is the mandibular nerve and the sphenopalatine ganglion, as we said, and the arteries we said, ascending palatine and the Vidian artery. These are the communication. There is something called boundaries and communication. For the infratemporal fossa, we said the boundaries and the communication. Now for the pterygopalatine fossa, we talked about the boundaries and the communications. The boundaries are the anatomical boundaries. Communications are where to go from the fossa. It's very logic. If you go anteriorly, anterosuperiorly, you will get the orbit through the inferior orbital fissure. If you go anteriorly, you will get the nasal cavity. Also, if you go medially, you will get the nasal cavity. Anteriorly, you will get the nasal cavity through the sphenopalatine foramen. And so there is a sphenopalatine foramen. You go from the pterygopalatine fossa, you enter the nasal cavity, and inferiorly, of course, there is the oral cavity. There is communication between pterygopalatine fossa and the oral cavity through the palatine bone called the palatine canal, reaching the oral cavity and the pharyngeal canal. And superiorly, of course, the foramen rotundum. You remember in the roof of the infratemporal fossa we said that the foramina are the foramen ovale and spinosum. Here the medial wall of the middle fossa, foramen rotundum, is present in the roof of the pterygopalatine fossa, but ovale and spinosum in the roof of the infratemporal fossa, and then the pterygoid canal also to the middle cranial fossa. Remember, the pterygoid canal is the canal carrying the greater superficial petrosal nerve, and through the pterygomaxillary fissure, as we said, to the infratemporal fossa. So anteriorly, nasal cavity, anterosuperiorly, the orbit, superiorly, foramen rotundum, pterygoid canal, middle fossa, and laterally, infratemporal fossa, inferiorly, oral cavity and nasal cavity through the palatine canal, and also anteriorly, sphenopalatine foramen, the nasal cavity. Here again, here are the boundaries, and you find the communications. Of course, here is the pterygomaxillary fissure. This is to not to perplex you, just a small reminder present before with the nerves to show you that the deep petrosal, which is a sympathetic plexus around the carotid, unites with the greater superficial petrosal, parasympathetic of the facial nerve, forming the median nerve passing in the medial canal called the pterygoid canal, and then they pass in the greater superficial petrosal nerve is the parasympathetic supply of the lacrimal gland, so it relays in the sphenopalatine ganglion to join the V3, to join the branches, sensory branches of V3, supplying the lacrimal gland and reaching also forming the lacrimal nerve of the V1, and the deep petrosal, which is sympathetic, also passes inside the sphenopalatine but without relay and supplying sympathetic to the lacrimal gland. If you remember, every parasympathetic ganglion has three types of fibers: a parasympathetic fiber relaying, a sympathetic fiber passing without relay, and sensory fibers passing without relay. This is the parasympathetic innervation of the sublingual gland. We said also that this is the greater superficial petrosal, sphenopalatine, lacrimal. Also the chorda tympani of the facial, relaying in the submandibular gland and supplying submandibular ganglion, the sublingual and submandibular salivary glands by joining the lingual nerve. Parapharyngeal fossa is a very important fossa also, and it is a space outside the pharynx, as you will see, parapharyngeal, beside the pharynx. So it is also medial to the infratemporal fossa, like the pterygopalatine fossa, and it is bounded posteriorly by the carotid sheath, as you will see, and anteriorly by the pterygomandibular raphe, medially, of course, the pharynx, and laterally the deep surface of the parotid gland. You will see it now, and the contents: parapharyngeal fossa, carotid sheath, and all the lower cranial nerves. The carotid sheath contains the vagus. Also we have the glossopharyngeal, 9, 10, hypoglossal, 12, and the accessory, 9, 10, 11, and 12. The lower 4 cranial nerves are present in the parapharyngeal fossa. Carotid sheath is present in the parapharyngeal fossa, and some deep cervical lymph nodes. So it is medial to the infratemporal fossa, bounded by the carotid sheath posteriorly, can be considered part of the content, anteriorly bound by what we call the pterygomandibular ruff, and medially the pharynx, laterally the parotid, contains carotid sheath, lower 4 cranial nerves, ascending pharyngeal artery, some lymph nodes. So this is also the view of the parapharyngeal space. Here, if you go through an axial view, the infratemporal fossa is here, medial and posterior to the infratemporal fossa. The Pterygopalatine fossa is medial, here is posteromedial, and as we said, the contents of the parapharyngeal fossa are the contents of the carotid sheath. If you remember, it contains the carotid artery, internal carotid, contains the internal jugular vein, it contains the vagus nerve behind them and between them, and embedded in the lateral surface is the sympathetic chain. So what are the contents? The contents are internal carotid, internal jugular, vagus, sympathetic embedded. So we finished the vagus. It contains also the hypoglossal nerve, as we said, contains the glossopharyngeal and the accessory. So it contains the lower cranial nerves with the sympathetic chain. It contains a very important artery, internal carotid artery, and a very important vein, the internal jugular vein, on their way to the skull base. If you go from inside, anterior to the anterior pillar, you can find here the carotid, you can find here the internal jugular, and this is a view, parapharyngeal space, present in this region, outside the pharynx, and medial to the infratemporal fossa. And we talked about the contents, as we said, and the surgical importance. We talk about first the surgical importance of the infratemporal fossa. Why are we studying all this hassle and all these details? Because you reach this fossa when you do the cranio-orbizygomatic approach, what you call the COZ, going to the cavernous sinus and interpeduncular fossa. Cavernous sinus because you removed, you go down, and so you will find the cavernous sinus uncovered by the sphenoid ridge. It's no longer there, and you can work there. And the more you go down, removing the zygoma, the more you can see up, reaching the interpeduncular fossa. So it is a corridor used during the COZ approach, and you can reach the infratemporal fossa and parapharyngeal fossa extracranially. If you want to reach them without reaching intracranial cause, you can reach them by removing the zygomatic arch alone. You don't have to take all the zygoma with it. And it is the site of many tumors, can be present here: rhabdomyosarcoma, liposarcoma, meningioma, schwannoma, angiofibroma, as we'll see. And the most dangerous structure to preserve here is the internal carotid artery, medial and posterior to the neck of the mandible. Always remember this relation while we are in the infratemporal fossa. This is the COZ approach, cranio-orbizygomatic. It's like the pterional approach, and you get the whole zygoma with the zygomatic arch. You can do it one bone if you want, or you can separate it doing the pterional. Then you take the lateral part of the roof of the orbit and the lateral wall of the orbit and the zygomatic maxillary suture and the zygomatic arch, and you get this view. All this bone is taken out, so you can look up and you can reach the infratemporal fossa. This is the picture when you open the dura. Of course, this is temporalis massa reflected. This is part of the zygomatic, part of the zygoma here, and all this bone is removed. I am capable of looking upwards and looking to the cavernous sinus, looking to the interpeduncular fossa easily. There is something called mini COZ. Sometimes I don't want to reach the infratemporal fossa, I just want to reach the upper part, interpeduncular. I take part of the zygoma, not the whole zygoma, and I don't take the arch. So there is COZ and mini COZ. This is another view of the mini COZ. It's exactly like the pterional, but we remove part of the zygomatic bone, not the whole zygoma. Tumors of the infratemporal fossa. Metastasis can reach anywhere. Here there is a metastasis in the infratemporal fossa. And rhabdomyosarcoma, you can reach it here. And schwannoma from the V3, mandibular division in the infratemporal fossa. And the angiofibroma. This is a very benign tumor and very good prognosis. It looks horrible in the MRI, and it looks like you can never take it out. Believe me, I operated more than about 37 cases of angiofibromas, and I do it with an ENT colleague. I take the part of the infratemporal fossa and dissect it from the floor of the cavernous sinus and leave it with the upper surface free, and then my ENT colleague goes with the endoscope in through the nasal cavity and he pulls on the tumor and take it out. There is no danger from pulling after dissecting it from the cavernous sinus from above. So I do the COZ to reach the angiofibromas in the infratemporal fossa. And as we said, the carotid artery is the most important structure to injure here. And one more thing I wanted to say, as you see, the infratemporal fossa and the parapharyngeal fossa are no man's land. When it is no man's land, we are the men that owe the land. Remember this: infratemporal fossa, Pterygopalatine fossa, parapharyngeal fossa, orbit. We are the men to owe this land when it is no man's land. And the carotid artery is present in the carotid sheath, forming the posterior boundary, as we said, of the infratemporal fossa, medial to the neck of the mandible. This is a very important relation, carrying some risk of injury during surgery. And you can identify the position of the external carotid artery by the site where the pressure on it makes the superficial temporal artery pulsations disappear. So it's a trick intraoperative to know where is the external carotid artery and consequently where is the internal carotid artery after that. When you press on a region and you get you lose the pulsations of the superficial temporal artery, so that you are compressing the external, and the external carotid artery is somewhere deep to your finger. And this is to show you the arteries. You know, if you remember, the internal carotid artery passing upwards in the carotid canal in the petrous bone, and the internal jugular vein is passing in the jugular foramen posterior to it at the skull base. On their way, they are present in the infratemporal fossa, medial to the neck of the mandible. It's another view showing the common carotid, external carotid here. This is the angle of the mandible, and you can their way to the skull. And here is the substance of the parotid gland dividing into the maxillary artery and superficial temporal artery, and it is very close, external carotid, to the temporomandibular joint and the angle of the mandible. Again, you can see it anywhere, but always remember that one of the contents of the infratemporal fossa is the carotid artery that we have to preserve and we have to respect, and it is present in the posterior part of the infratemporal fossa, and it is medial to the condyloid process, medial to the temporomandibular joint. Always remember this, but deep. Actually, it is deep. External carotid artery is more superficial. And these are the terminal branches, superficial, temporal, and maxillary. Thank you very much for your attention, and I hope we will meet soon, and I mean it soon, inshallah. We are going to meet in one or more of the most interesting subjects. We will talk about the applied neuroanatomy, and the good news is that we are approaching the end of this series, but we are still having like 8 or 9 lectures again left, so that we can finish this series totally. And by finishing this series, this I think is all what you have to know as students interested in neuroanatomy and skull base, or as neurosurgeons going to work in the region of the brain or the skull. Thank you very much again, and we hope to see you soon. And I'm very happy with your comments. Please don't hesitate to give me any comment, any judgment, any question. I'll be more than happy to answer it. Thank you.